So hello, my name is Philippe Moreau, and I'm working at the University Hospital of Nantes in France, and I'm going to present some of the key data from the COMy meeting, the ASCO meeting, and EHA 2025 as well, on BCMA-directed therapies in patients with relapse and refractory myeloma. And then I will be joined by my colleagues, Dr. Paola Neri from Calgary, Canada, and Prof. Hermann Einsele from Würzburg, Germany, to discuss the clinical implications. And first, I will focus on some of the data from these congresses relating to the approved indication for BCMA-directed therapy. So, interestingly, we heard both at ASCO and EHA the long-term remission and survival after treatment with cilta-cel in the CARTITUDE-1 patients with relapse and refractory multiple myeloma. You remember the CARTITUDE-1 schedule. Cilta-cel single agent was proposed in very advanced patients, and 97 patients with heavily pretreated relapse and refractory myeloma did receive cilta-cel. And the data were presented with a very long follow-up, a 5-year follow-up, to look at the overall survival and progression-free survival. Interestingly, with this long follow-up of 61.3 months, in fact, we have 32 patients that are alive and progression-free. It means that 1/3 of the patients did not relapse. We try to look at the baseline characteristics according to progression, yes or no, to try to identify who were the patients who did not relapse. And in fact, apart from tumor burden, there was no specific baseline characteristics of patients with a progression-free survival above 5 years. Interestingly, when we are looking, in fact, at some biomarkers that could predict or associated with a progression-free survival that is above 5 years, in fact, we see that there is this T-cell neutrophil ratio before the infusion, and you can look at this ratio very easily. And we can also look at the ET ratio at peak expansion post-infusion. So what is this ratio? In fact, it is the CAR-T normalized by pre-infusion serum BCMA levels. So these biomarkers are able to predict a better progression-free survival. So what is very important, to my opinion, is that we have now a plateau, and there is a very small subgroup of patients who were evaluated for MRD negativity, both within the bone marrow and also with PET-CT every year. And this small group of patients, 12 patients from a single institution, did not show any MRD positivity and any PET-CT positivity. It means that potentially the conclusions were very provocative. Some patients might be cured by cilta-cel single agent 1 infusion, and that's very good news for the patients. We also had another presentation regarding CARTITUDE-4. And CARTITUDE-4 is a prospective study comparing cilta-cel versus standard of care in patients with relapsed myeloma at earlier lines of treatment. And we looked at some subgroups of patients with or without extramedullary disease, and patients with 1, 2, or 3 lines of therapy with a median follow-up of roughly 3 years. And what we can see is that definitely for patients with extramedullary disease, that is a very, very poor subgroup of patients, in fact, in terms of prognosis, the median PFS with cilta-cel is 12 months versus 4 months for standard of care, and the median overall survival is not reached versus 15 months, and those differences are, to my opinion, very important. When looking also at prior lines of treatment, patients with one prior line of treatment, the progression-free survival is highly in favor of cilta-cel versus standard of care. And in this setting, the standard of care regimen was mostly dara-pom-dex. This is also true for line 2 with a hazard ratio of 0.3 and for line 3 with a hazard ratio of 0.2. So definitely we have those subgroups analyses that are showing the strong benefit with cilta-cel in patients with relapsed myeloma at earlier lines. This is also true for overall survival indeed. So this is really confirming that when you are able to use cilta-cel, especially in patients with len refractory multiple myeloma, the outcome will be improved. We heard as well about real-life data with elranatamab, and you know that elranatamab is a bispecific antibody targeting BCMA that is approved by FDA and also by EMA. And we've heard about some real-life data with this agent in very advanced patients. To date, only one paper is published with real-life data with ELRA, and we've heard about this presentation from 5 sites within the UK, looking at the outcome of 43 patients. And indeed, when focusing on efficacy, the overall response rate is quite good, 71%. So we are really looking at the same response rate as compared with the pivotal study of the approval of elranatamab, that is a MagnetisMM-3 study. And when looking at the 6-month PFS rate, 63%, the 6-month overall survival rate, 81% indeed. And that's good news that we can reproduce the results of the pivotal study, of course. And the PFS was not affected by a prior exposure to anti-BCMA. That's also very important, although the numbers were very small. And also the PFS doesn't seem to be affected by poor cytogenetics. When looking at the safety in this real-life setting, in fact, the CRS rate, 60% as expected, I would say, without grade 3. And the infection rate, grade 3 or more, 37%, keeping in mind that 2/3 of the patients did receive IVIG replacement during the treatment with ELRA. And we've also heard about an indirect comparison of linvoseltamab versus elranatamab for triple-class exposed and refractory multiple myeloma. So linvoseltamab is the third-in-class BCMA agent, bispecific antibody, very recently approved a few weeks ago by EMA. And the goal of this comparison was to try to identify what was the outcome in triple-class exposed and refractory patients. So the authors did compare MagnetisMM-3 cohort A. MagnetisMM-3 cohort A with elranatamab is the pivotal study for the approval of ELRA on 123 patients, in fact, and they compared those patients with 117 patients who did receive linvoseltamab at the optimal dose of 200 milligrams, according to the linker MM1 study, the pivotal study for the approval. So that's a match-adjusted indirect comparison. Patients were matched for several different clinical and biological factors. And when you are looking at the overall response rate, 72% for linvo, 61% for ELRA. The CR rate seems to be slightly higher as well, with linvoseltamab 51% versus 37% with ELRA. And the median PFS is not reached in favor of linvo versus 17.6 months with elranatamab. And we know as well that the median OS was 2 years with ELRA and is not yet reached for linvoseltamab. So we have to be very careful, when we are seeing those data, to my opinion, because the patients who are not treated exactly at the same time, not in the same centers, etc. So I will be very careful, and I don't want to claim that one is better than the other. And now I would like to welcome my co-faculty, Paola and Neri, and Hermann Einsele, to discuss the clinical implications of these new presentations at ASCO, COMy, and EHA. So the first question maybe for you, Hermann, what about the long-term results from CARTITUDE-1?
No, Philippe, I was really impressed about the CARTITUDE-1 long follow-ups data, always remembering that these patients had received 6 prior lines of therapy, 84% were triple class refractory, and 5 years after the CAR T-cell infusion, without any additional treatment, these patients were disease-free, and the subgroup of patients you nicely presented were actually also MRD negative and imaging negative. So the option is that these patients really are cured. So I think this was really impressive. I think the question that we now have, if CAR T cells are so effective in this late line of therapy, should we really use them early? I think there are a lot of data which supports an earlier use, because we know the T cells are fitter, the tumor is probably more immunogenic, the attrition rate always has to be considered. But I think with these data, this is something we really have to consider. On the other hand, now looking at the CARTITUDE-4 data, and the progression-free survival seems to be better when compared to CARTITUDE-1. And we also know from the bispecific antibodies that if we use them in earlier lines, they are also more effective, higher overall response rate, higher CR rate, longer progression-free survival. So for me personally, I would rather go for an early application of CAR T cells.
Thank you, Hermann. Very important comments for sure. But Paola, well, definitely when cilta-cel is available at earlier lines, according to the results of CARTITUDE-4, what do you think about the toxicity? Because we need to be also on the safe side. The efficacy is very, very important, and is compared in this phase 3 randomized study versus POMVD or DARA-PD for the majority of the patients. Cilta-cel definitely seems to be the best option, especially in len refractory patients that were the patients enrolled in CARTITUDE-4. But do you have some concerns regarding the safety of this BCMA CAR-T?
Definitely, Philippe, you are actually bringing an important point. So we are not doubting the efficaciousness of the approach, but we need longer follow-up to make sure that when we bring it earlier on, in early relapse, is safe. And when I say safe, we cannot ignore even if they are small, the second malignancy that we see in some cases. We cannot ignore the neurotoxicity that some patients experience. So I think we need to learn a bit more which factor, for example, can be for us very important to watch for. And I will also add in terms of the biomarker of response. So to make the point, because we all have tried to understand, can we predict if the patient we have in clinic will be a longer responder or not? To Hermann's point, we know that the T cell fitness is key. So we need to make sure that we don't go directly from a T cell engager to CAR T, because that could be probably an issue, and we'll probably discuss that in a later point. But I will say the understanding what is the quality of T cells. You mentioned having more naive cells definitely is an important predictor factor of longer response. So let's look at that. We should also consider which bridging therapy these patients have received. So there are factors that we know, but there are a lot also that we need to discover to really identify even that third of patients you mentioned, they are potentially cured. And I like the idea of thinking that could be the case. But what exactly these patients are, what are their characteristics, I think is something that we all as a community discover and understand a bit more.
Thank you, Paola. But well, the access is a big issue, in fact, with cilta-cel, and in many, many countries, in fact, We cannot use yet cilta-cel at earlier lines according to CARTITUDE-4. So for today, in fact, many of us are using cilta-cel in very, very advanced patients. And we also have another CAR-T that is available, ide-cel, and we have these 3 bispecific antibodies. Tecli was the first, teclistamab, the first to be approved. Subsequently, elranatamab was available, and now more recently, linvoseltamab. So how are you making your choice, in fact, and what are the factors that will drive, your selection according to CAR-T versus bispecific, if you have some choice, in fact, Paola, in your routine practice outside of clinical studies?
Absolutely, Philippe. So you mentioned the availability. So slot will and is right now the major limiting factor. So we would like to use a bit more CAR-T, but there are not too many slots available, and I will add the hospital are not ready to have several patients going for CAR-T in a month. So human resources slot is an issue. I will also add the kinetics of the tumor. So you mentioned disease burden as a factor that actually if you have less disease, patients do better. But we all know in our practice, we may have patients where their disease grow very rapidly. So these are patients where we cannot wait to do the collection, to wait for the 5 weeks to the infusion. So I think the kinetics of the disease, so in patient rapidly progressing, having access to T-cell engager, and even there, I will say right now, based on availability, what we have access to, that seems to make a lot of sense because they are off the shelf and patient can be treated immediately. We don't have to wait. The other piece I would like to add is what we know about the resistance mechanism. So we are learning that sometimes the tumor become resistant to, let's say, T-cell engager because they lose the target. So it's very important for us before switching therapy, understand if the target we're going after, we are focusing here on BCMA, is the expression of the target still there? There is a mutation in the target there because that will eventually influence our decision on which therapy to use.
Very important points, Paola. Thank you so much. And my last question for you for this discussion, Hermann, what is, to your opinion, the value of those indirect comparison, those match-adjusted indirect comparison? We know that I presented the data of linvo versus elra, but we also have one comparing teclistamab versus elranatamab. Is this very important for you to select one bispecific antibody versus the other? And are you really reading very carefully the real-world outcomes of our patients? And is it helping you to guide your selection in clinical practice?
I think, honestly, I see these indirect comparisons of limited value for making any clinical decisions. I think we have to consider that these bispecific antibodies, and you're specifically referring to these bispecific antibodies, were used at different time points. So some of the bispecifics that were in earlier use, they were quite heavily affected by the COVID pandemic, which really had an impact on the outcome of the treatment with these bispecific antibodies. Then I think there is also a learning curve. We have really learned that we have to use IVIG, that we have to monitor infectious complications. We have to give antimicrobial prophylaxis to make it safer. So the later reports about bispecific antibodies are benefiting from this kind of learning curve. And the other thing is, and that's a point that you have mentioned and criticized at several meetings, is that a lot of these studies on bispecific antibodies in real world have a very short follow-up. So often we don't really see what's going to happen. And now there are increasingly new strategies involved, like spacing out the application, which also has an impact probably on the rate of infectious complication, but also on the efficacy. So with all this, I think, at least for me, I see limited value of these indirect comparisons But I guess we will never see a direct comparison because I think the companies are not really keen on having a test between two bispecific antibodies in a randomized trial.
Yes, of course, we will never have a prospective comparison of Tecli versus ELRA or ELRA versus Limbo. Paola, do you think that some real-world data may inform regarding the use in routine of bispecific antibodies in some subgroups of patients that were not, in fact, enrolled in the pivotal studies, such as patients with a renal failure, or patients very old? Is it interesting to analyze this data, in fact?
Yeah, I will agree because the real data will help at least to enroll more patients. The real patient are selected, and therefore we will learn if it's safe and what is, the right scheduling for this group of patients you are mentioning. I will add that for sure the access is probably the factor that right now will dictate which anti-BCMA T-cell engager to use, and probably with time, because we are really in the early days of this new molecule. So it will, in few years, we will know what is different in terms of mechanistically, right? The affinity to the target. Are they able to bind? The fact that some are monovalent binding to BCMA, other bivalent BCMA binding domain to the BCMA, is that indeed a differential factor? I think, we're all even there at the early days, and probably with time we'll understand what is unique about one anti-BCMA to the other. But I will agree they are not identical, and probably later on we'll know which group of patients to use each of them specifically.
Yeah, maybe it also for some subgroups like patients with extramedullary disease, which haven't been so much included into the studies with bispecific antibodies. And I think now we have learned from real world data that probably extramedullary disease is an issue for the treatment with bispecifics, and probably have to add something to make it more effective in this subgroup of patients.
So thank you so much, Paola. Thank you, Hermann, for these very, very important comments and great discussion. Hello, my name is Philippe Moreau, and I'm working at the University Hospital of Nantes in France. And in this section, I will now focus on some of the latest data from the congresses regarding the practical application of BCMA targeting agents in relapse and refractory multiple myeloma, including their sequencing. And we heard about very interesting data at COMy, at EHA, and ASCO 2025. And one talk focused on the sequential BCMA CAR T-cell therapy in patients with relapse and refractory multiple myeloma. So we don't have a lot of data, to look at the sequence of two CAR Ts, in fact. So the goal of this presentation, small number of patients, 10 patients only. Those patients were treated first with ide-cel and second with cilta-cel. And obviously, the authors looked at the expression, in fact, of BCMA on the tumor cells before using sequentially those CAR Ts. And in terms of efficacy, in fact, the response rate with cilta-cel after ide-cel first, the response rate is very good, 100% of response. And in this small series of patients, the median interval between the CAR T-cell therapies were almost 2 years. And when looking at the efficacy, the 6-month PFS rate is 65%. So it means that in the real world, we can sequence CAR T-cell therapies, and if the patient did receive ide-cel first, and ide-cel was the first CAR T available, as you know, then you can rescue the patients at the time of the progression with cilta-cel with quite a good efficacy, looking for sure before the infusion of cilta-cel that the target is still expressed on the myeloma cells. There was one factor that was affecting, in fact, progression-free survival after ide-cel. It was the duration of response following the first administration of CAR Ts. And when patients had a PFS that was shorter than 1 year after ide-cel, the outcome was significantly poorer, in fact, following the retreatment with cilta-cel. We also heard about a quite interesting study from the French group, again, small numbers, but we will have more and more data available for sure in the coming month to evaluate the efficacy and the toxicity of BCMA bispecific antibodies post-GPRC5D bispecific antibody. Currently, we have one bispecific antibody targeting GPRC5D that is approved, that is talquetamab, and the authors looked at talquetamab first, or forimtamig that is also targeting GPRC5D in the GRACE clinical study, and the patients at the time of the progression did receive either teclistamab for the majority of them or elranatamab. So that's small study, retrospective analysis, 26 patients only, but interesting nevertheless regarding efficacy. The response rate was 58%, and that's not very different from the 61-63% of response that was achieved in the pivotal MajesTEC study and the pivotal magnetism-free study for elranatamab. And when we are looking at the median progression-free survival, this PFS obviously is shorter. That's 5.3 months. And the overall survival, the median overall survival, is roughly 16 months. So it means that you can use GPRC5D at the time of the progression, use a bispecific targeting BCMA, and you can induce quite a good response rate. From a safety point of view, there was no new safety signal from this small series of patients. We've heard also about the safety results from the REALITEC study and some subgroups analysis. So REALITEC, in fact, is a retrospective international study looking at the efficacy of teclistamab outside of clinical trials across 8 different countries with 23 sites. And the number of patients is quite interesting because we looked at 113 patients, and some of them were previously treated, 1/3 of them were previously treated with a prior BCMA treatment. So what are the data regarding the efficacy? In fact, 60% of response. So that's exactly the response rate of MajesTEC-1. MajesTEC-1 was 61% of response. And in patients with a prior BCMA exposure, that's 1/3 of the patients, the response rate is not bad. In fact, 53% of response. And when looking at the patient characteristics, we know that in the real life, we are not exactly treating patients with the same inclusion or exclusion criteria as MajesTEC. Many of them would not have been elected, for MajesTEC-1. And in fact, patients meeting MajesTEC-1 eligibility criteria had significantly better outcome versus those who did not. And the safety profile is really confirming that the CRS rate, 56%, with no grade 3, the infection rate, grade 3, 39%. And we know that we have this learning curve, in fact, and the infections over time are decreasing, because we are treating and we are using more and more IVIG supplementation. And in many centers, we are using IVIG during the first month of therapy. We also heard about the safety and efficacy of a less frequent dosing with elranatamab in patients with relapse myeloma. That's a US subgroup analysis from Magnetism-3. That was the pivotal study for the approval. And in some centers of the US, they looked at a different schedule. Patients did receive elra weekly dosing for the first 6 cycles. And then when they did achieve a response, they were transitioned to an administration sub-Q every 2 weeks, and then monthly after 6 additional cycles of Q2 week dosing. So we know that the schedule of administration is a very, very important topic for bispecific antibodies, TECLI and ELRA, sub-Q weekly every 2 weeks. And then for patients that are responding, we would like to move to a monthly administration, in fact, of bispecific antibodies. And in this small series, 47 patients, the response rate was 66%. The median PFS was 27 months. So it means that you can probably modify and change the schedule, especially when patients have a very good partial response, or at least a PR, switch to every 2 weeks or monthly administration. This is really feasible, and that will not affect on the efficacy of this treatment. And then we heard about some data regarding the clinical management of belantamab mafodotin associated ocular events. That was an expert experience program. We know that belantamab mafodotin, that is an antibody drug conjugate that is targeting BCMA, is associated with a significant ocular toxicity. This agent is not available. In fact, it was in the past, but the treatment was stopped, in fact, after some, let's say, negative results. But now we have 2 important studies, the DREAM7 and the DREAM8 phase 3 data that are really showing that Bela, in combination with VD, the Bela-VD regimen, or in combination with Pomdex, the Bela-PD combination, is associated with a very, very good response rate, a very good progression-free survival versus standard of care. So we need to understand better, and we need to develop practical clinical recommendations for the management of this specific ocular toxicity. So a panel of experts are proposing now 11 recommendations from the very starting point, the screening phase, and then how to adjust, in fact, the dose of Bela, how to mitigate, in fact, to tailor dosing to mitigate the risk of myeloma relapse when you are decreasing the dose or when we are delaying the dose, and what could be the optimal collaboration with the eye doc, in fact. Some interesting recommendations were proposed by this panel of experts. And now I would like to welcome my co-faculty, Dr. Paola Neri, working in Calgary, Canada, and Prof. Hermann Einsele from Würzburg, Germany, to discuss the clinical implications of these data. And maybe Hermann, starting with you, what are the key factors that are helping you in your routine practice to select or to try to optimize the best sequence? You know, BCMA, GPRC5D, what is your preferred target when you want to start in a triple-class refractory patients? And then how to sequence CAR-T and bispecific antibodies as well?
No, thank you. So first of all, I still see the most effective treatment that we have available just now is a CAR T cell. So I would go for, if the patient is suitable, that means we can control the disease until the CAR T cell product is ready, the patient can tolerate CRS and ICANS, then this patient would be a candidate for a CAR T cell therapy. If the patient relapses after BCMA-directed CAR T cell therapy, you have nicely shown the data of using a second BCMA-directed CAR T cell product. It was shown in the COMy trial, if you use the same construct again, then you have anti-drug antibodies and the efficacy is rather low. So definitely, if you want to use a second CAR, you have to switch the binding domain. And I think in this study, it was nicely shown, especially in patients that had a long-term remission after ID cell, that then they could benefit from a second BCMA CAR T-cell therapy with cilta-cel. Now, I guess this is only very rarely available in Europe to do a second CAR T-cell therapy. So I probably would go for a bispecific antibody. And because the antigen loss after CAR T-cell therapy is only about 4 to 6%. So you have the option in a patient who still has a BCMA expression, and we would actually do an immunohistochemistry, look for BCMA expression. We probably would do a soluble BCMA determination to see that there is still soluble BCMA around, and maybe go for a genetic analysis to see whether there's a biallelic loss or a mutation. But only in a biallelic loss, I guess, if there is a mutation which hasn't really been described following CAR T-cell therapy, then you can go for a BCMA bispecific. If there is an antigen loss, then the next step would be to use a GPRC5D targeted therapy. Talquetamab, we have a bispecific antibody available and in clinical trials. We also have GPRC5D targeting CAR T-cells that can be effectively used, as has been shown in several trials following BCMA CAR T-cell therapy.
If I can add, Philippe, as well on this topic, in Canada, for example, I don't know how it is in Europe, we cannot use a GPRC5D target therapy before a BCMA. So patients need to be exposed to BCMA first, and then eventually go to GPRC5D. And the other point I want to make biologically too, we know BCMA seems to be more important for a plasma cells to be a plasma cell. So if I have a choice of both, I will still go for I agree with Hermann, with a BCMA target therapy first, and then eventually switch to GPRC5D. The other factor is important, we're talking about, predicting resistance to this therapy. Some patients, especially the relapse refractory, already have a baseline monoallelic loss of the GPRC5D, and that makes them maybe more prone to get eventually mutations. So we have to be very careful in sequencing, but again, BCMA still remain my first target.
Okay, thank you for those very, very interesting comments. And Paola, how do you approach, in fact, the management of CRS in your routine practice? Because we heard from many, many authors and now colleagues that there are a lot of outpatient programs, for during the step-up phase, during the first week. The patients in your center are staying in the department for 1 week, or are you able to treat them outside the hospital during the step-up phase? What is your choice, in fact?
So right now we are still admitting patients for a week during the step-up dose, but we are really looking forward to see more data coming from the US, where preventively use of TOC, so the anti-IL-6 pre-meds with steroids seems to be allow more patients to receive therapy in the outside setting, in the outpatient setting. So for now, it's still for safety. Again, close monitoring. It's much easier for a patient, for the nurses, and for us to see them. So for now, it's still 7 days in the inpatient. This is just because we know this first week is probably the most important one from the CRS and ICANS point of view.
And we've heard about the prophylactic use of tocilizumab to further reduce the risk of CRS. CRS, that's mostly with bispecific antibodies grade 1 or 2, so not very dangerous, let's say, but nevertheless in 60-70% of the patients. So are you using prophylactic TOC to reduce this risk of CRS up to, for example, 20% only?
Yeah, not in all the patients. And the other thing we have noticed, Philippe, I don't know if your experience too, that to preventively TOC sometimes make these patients cytopenic for a very long time. So we don't really use it routinely unless, again, there is a fever and then there is a real concern of CRS and ICANS.
I think one issue.
Yes,
sorry. One issue clearly is if a patient goes into treatment with a bispecific with a very high tumor load, this patient has a much higher risk of developing a severe CRS or a neurotoxicity. And so I think debulking is also key. The same is the bridging therapy and with CAR T cells to really reduce the tumor load and then make the bispecific more safe. In a patient who goes in with a very high tumor load and we just do not have any option apart from using a bispecific, then we would probably consider giving prophylactic toxi.
Thank you. And for CAR T-cell therapy, Hermann, we know that the CRS is very predictable, I would say. We know that with ide-cel, the median time to onset of CRS is roughly 2 days. The median time to the onset of CRS with cilta-cel, slightly longer, roughly 5-7 days. So are you using prophylactic toci in this setting, or are you just carefully following the clinical parameters of your patients?
Absolutely, the second point. So we monitor the patient, and if the patient develops a CRS grade 2 at least, we would go in with toci. If he develops a neurotoxicity, we would go in with dexamethasone very early to prevent it. And I think what we have learned from different trials is that the bridging therapy is very important. If you get a patient in a good response prior to CAR T-cell infusion, the risk of neurotoxicity and CRS is clearly lower. And there are some data now also about the lymphoproliferation you see following CAR T-cell infusion. So in a patient who has a high lymphocyte count around day 10 to 14, that these patients of 5,000 or higher, that these patients have a higher risk of developing this late neurotoxicity, especially the cranial nerve palsies. So there's one suggestion now to introduce dexamethasone in these patients who have an intensive lymphoproliferation about day 10 to 14 following CAR T-cell infusion.
And regarding infections, and mostly for bispecific antibodies, because very often you are mentioning that, well, there was a learning curve. We're starting with teclistamab, and then the grade 3 or 4 infection rate was very high, indeed, above 50% at first. And then when we were using systematically IVIG, the rate of infection did decrease, and in fact, that's now much lower. Are you, both of you, using systematically IVIG from the very first month of treatment with teclistamab, elranatamab, and in the future, linvoseltamab? That's what you want to do?
So we do. And we also give antimicrobial prophylaxis. So we give acyclovir and Cotrim prophylaxis. And we also, in patients that develop fever, we would also monitor these patients for opportunistic infections. And if, for example, they have a high CMV load, we probably would also consider anti-CMV treatment in these patients. But I think a second very important point is the spacing out of the bispecific antibodies in a patient who has a nice response. So in a patient who achieves a partial remission, or even more, if he achieves a complete remission, we would very early start spacing out to at least 2 weeks, and we have already now doing 4 weeks in some of our patients. And they remain in remission, and at least not having done a very thorough analysis, but it looks like these patients have less infectious complications.
Thank you, Hermann. And Paola, we are now going to use probably in the near future belantamab mafodotin again, especially in combination with VD, the Bela-VD combo, or PD, the Bela-PD combo, according to DREAM7 and DREAM8 results. Canada was one of the first countries, to propose Bela in combination with PD, and now we have strong phase 3 data suggesting that this combination could be very effective, especially in LEN refractory patients at the time of the first relapse when cilta-cel is not available. But how do you think that you are going to take care of your patients with this ocular toxicity? Do you think that we need this multidisciplinary collaboration, etc.? Or what are your views, in fact, on belamaf?
Yeah, a good point, Philippe. The ocular toxicity is indeed an issue that we have seen and is very, unfortunately, has a negative impact on patients. So what we're learning, though, that in the past, we were using the wrong dose. We were very intense in our approach. Now, especially with the combination, we know what is the dose. We know that we can pause safely if patient has an ocular toxicity, let them resolve or recover fully, because in most of the case, the ocular toxicity is reversible, and eventually restart. So I think we initially were using the very high dose, and we were afraid to lose the response when we were doing the pause. Now, the study that you also have presented show that we can indeed achieve a deep response very quickly. And then when there is an ocular toxicity, pausing is safe. And then we can do the 3 months injection that there seems to be many centers are used. In terms of expertise, you mentioned we need a multidisciplinary approach here, because we need an ophthalmologist evaluating the patient initially, and also before any injection, any infusion. Therefore, I think that will be the practical aspect. The many centers will have a hard time to implement, which is really this need of several expertise before we did treat patients. But to your point, is indeed another option that some patients can actually benefit from.
Thank you so much. So thank you, Paola. Thank you, Hermann. Very good comments, very interesting comments. Hello, my name is Philippe Moreau. I'm working at the University Hospital of Nantes in France. And in this section, I will focus on data from recent congresses on emerging BCMA-targeting agents and combinations that may influence the future management of relapse or refractory multiple myeloma. And during recent meetings at COMy, at ASCO, EHA 2025 in Milano, we've heard about some subgroup analysis of the DREAM7 study for high-risk patients, and also in patients by subsequent therapy. You remember that DREAM7 is a prospective phase 3 study for relapsed myeloma patients who did compare in almost 500 patients Bela-VD, Belamaf plus bortezomib index versus daratumumab plus VD, and showing a strong benefit in favor of Belamaf in terms of progression-free survival and also overall survival. But when focusing on patients with poor cytogenetics, definitely there is also a very strong benefit of Bela-VD versus Dara-VD. The 18-month overall survival in patients with at least one cytogenetic abnormality is 80% versus 66% with Dara-VD. And when looking at the efficacy by subsequent therapy, it was possible at the time of the progression on Belamaf to use some CD38 based combinations, or combinations based on pomalidomide or carfilzomib, with a quite long progression-free survival, indicating that a treatment with Bela in combination is not impacting the next line of treatment. We've heard also about DREAM8, and DREAM8 is a prospective comparison, phase 3 again, in relapsed myeloma patients, comparing Belamaf mafodotin in combination with Pomdex, the Bela-PD combo, versus pomalidomide, bortezomib index, the Pom-VD combinations, in patients with at least one prior line of treatment, all of them previously treated with lenalidomide. And definitely the DREAM8 is showing very, very good results, and we heard about the update efficacy and safety. In the Bela-PD arm, the median PFS is 32 months. That's very, very long, as compared with 12 months with Pom-VD. And 12 months is, I would say, as expected. So the control arm is an adequate one, but the hazard ratio is 0.46 in favor of the Bela arm of the study. So we also looked at some subgroup analysis of this DREAM8 regarding cytogenetic risk, len refractory patients, 1 prior line, more than 2 prior lines of treatment, and across all these subgroups, Bela is doing better than the POM-VD combination. We also looked at the efficacy by high-risk cytogenetics and by MRD negativity status, and definitely the median PFS for patients with at least one cytogenetic abnormality is 21 months, in fact, with Bela versus 9, I would say, only with POM-VD. When looking at the rates of MRD negativity, definitely this rate is 5 times higher with Bela PD versus POM-VD, roughly 1/3 of the patients, 35% of the patients are reaching MRD negativity versus 5% only with POM-VD. Another CAR-T is in development, and this CAR-T is also targeting BCMA, but the construct of this CAR-T, and the name is anito-cel, is different with another D-domain binder, in fact. And this new CAR-T, anito-cel, was tested in a large phase 1b, phase 2 study, and we've heard about the results on 117 patients, in fact. That's quite a large phase 2 study, and that's the registration study for anito-cel in relapse and refractory multiple myeloma. So all patients were very advanced, at least 3 prior lines of treatment, refractory to the last line of therapy. And the efficacy is very good, 97% of response. So that's roughly the same response rate as compared with cilta-cel. And the progression-free survival at 6 months and 12 months is also very, very high. So very, very good response rate, long PFS, and also a long overall survival. So, and in terms of safety, the CRS, well, is, let's say, manageable with very few grade 3 CRS. We have also a very low rate of neurotoxicity, what we are calling early neurotoxicity ICANS, and no delayed or non-ICANS neurotoxicity. So maybe this CAR-T could be, let's say, as effective as cilta-cel with a lower toxicity. So definitely we need a longer follow-up, but probably this new CAR-T will be available soon, hope in the next month. We heard about the combination of a new bispecific targeting BCMA, that is linvoseltamab, with carfilzomib. So this is the linker MM2 trial. And we know that we can now combine this very active bispecific antibody with, let's say, proteasome inhibitors, but there are also other developments, not only with carfilzomib, but also with bortezomib and with IMiDs. So the goal is to try to use these antibodies at earlier lines in combination with, let's say, old agents in order to increase the efficacy. There is a big competition when speaking about bispecific BCMA antibody. 3 are approved: teclistamab, elranatamab, and very recently, a few weeks ago, linvoseltamab in Europe by EMA. But there is also another one in development, etentamig, what we are calling ABBV-383. And we've heard about the long-term efficacy of safety of this bispecific antibody in relapse and refractory myeloma. And all patients were very advanced. The response rate, very consistent, 66% of response. And looking at the PFS rate at 1 year, 55% of the patients, and the duration of response, expected duration of response at 1 year, 71% of the patients. So we will have definitely a competition, and that's true that the schedule administration will change because we are moving to the sub-Q administration, to the IV administration, and we are also using monthly schedules that could be more convenient for patients and also for the staff taking care of the patients. And very importantly, maybe some best presentations at ASCO, EHA. We've heard about the first in-human study of a tri-specific antibody targeting both BCMA and GPRC5D. And we've heard also about the phase 1 first in-human study of a tri-specific antibody, another one targeting CD38 and BCMA. And the results are really fantastic, to my opinion, especially the antibody targeting both BCMA and GPRC5D, monthly administration, fixed dose, 100% of response in very, very advanced patients. So we see now that the options will definitely increase in the near future. Potentially, tri-specific antibodies will take the lead versus talquetamab, teclistamab, ELRA, Linvo, etemtamig, etc. Fantastic response rates. And the development is so fast that we are already thinking of using those tri-specific antibodies at earlier lines of treatment. And now I would like to discuss these interesting data and to welcome my co-faculty, Paola Neri, working in Calgary, Canada, and Hermann Einsele, working in Würzburg, Germany, to discuss about the clinical implications of these data. So first question for you, Paola. Based on the DREAM7 and DREAM8 results, where do you see belamaf mafodotin-based combinations in the landscape, with now more options, and we've heard about CARTITUDE-4 data with cilta-cel at earlier lines, a phase 3 study, very strong data. So how do you think that we are going to use belamaf in the future as soon as Bela approved and reimbursed with PD or VD?
Yeah, good question, Philippe. I have to admit, in my mind, the ocular toxicity remain an issue. So if I have access to alternative, I will really reserve belam for a very small group of patients, because we cannot ignore the need of having, caregiver with the patient all the time. The ocular toxicity is an issue, although we recognize, and you have shown that is more manageable. One group of patients, I was very intrigued to see the subgroup analysis, the IRIS patient, although it's not probably the newest IRIS definition of the IMS that we just published, but still there is a good signal that in certain patients with the IRIS, Bela can definitely be a good option. But in my mind, it's still for a very small number of patients if I have access to especially CAR-T and other anti-BCMA T-cell engager.
And Hermann, what do you think about the results of DREAM7 and DREAM8? Do you think that may impact your practice?
I think it does. Actually, it's apart from cilta-cel, which we can use in my country in second line, this is the only BCMA-directed treatment that we can also use in second line. And so I think we are increasingly probably using belantamab mafodotin in the combinations of DREAM7 and DREAM8 in second line treatment. What I'm a bit concerned about is the response to subsequent BCMA-directed therapy. We know that belantamab is not inducing T-cell exhaustion. There are very few reports about inducing mutations and biallelic antigen loss, but still there are data that clearly show that if you pre-treat a patient with belamaf, that this patient is less likely to respond to BCMA-directed CAR-T cells and BCMA-directed bispecific antibodies. So I think we have to very carefully watch this. It's a small patient cohort and we have limited data, but I think that's something we have to be concerned about. About the ocular toxicity, I think with the spacing out of the applications, it seems to be much better tolerated. And so probably it's an interesting concept, especially for patients where we feel that they are not suitable for CAR-T cell therapy or they have infectious complications, which probably prevents us from putting these patients on a bispecific antibody. So I think it's a real addition to the treatment armamentarium that we have. But in a patient who qualifies for a CAR T cell or for bispecific, I'm slightly hesitant to use it.
Thank you, Hermann. And Paola, that it seems that, well, the more we are treating patients, the more options we have, the more toxicities we have to manage. In fact, a long time ago, bortezomib, we had a big issue with neurotoxicity, but after a learning curve, we were able to control this neurotoxicity. For IMiDs, it was the DVT that was really a big issue. And now, well, no one is speaking about thrombosis, with IMiDs. The same for daratumumab. We were, well, fearing a lot of reactions that now we are not facing at all. We learned how to control CRS, and now we are discovering this ocular toxicity. So how do you explain all these options and toxicities to your patients? And are the patients really asking you in your routine practice, well, what could be the toxicity, what could be the efficacy, and are you selecting the best option with also a sort of dialogue with your patients and patients' choice, in fact?
Yeah, absolutely. So you bring the point how much how important safety is versus real efficacy, right, of the treatment that we have right now. I can share with you the fact of, so in my mind, we have to, I try to have, of course, safety become really the important point, especially if we think about early relapse. So these are patients where we want to use something that will be effective, but will be safe. And of course, we don't want to lose patients for an infection or for a secondary malignancy with a myeloma in remission. This is something that from my perspective, and many, of us have echoing this, we need longer follow-up of the safety perspective because, again, we don't want to have a safety issue. In the late relapse, I think we are a bit more open to explore options where, there are certain unknown and some safety issues. But going back to the question and discussion with patient, for example, you will expect after ASCO, a patient walk into my clinic and say, I want this because I read this is a potential cure for myeloma. And then this is up to us to say, it is true, it's fantastic, but it's only a third of patients. Let's talk about toxicity or safety. So to your point, is always a discussion between yourself where you share the data available right now and the fact that there are trials ongoing and the issues in terms of early, safety concern, and I would say even more longer term safety, which again, they are still an issue we have to discuss.
Thank you, Paola. And Hermann, you heard about the etentamig results. What are your expectations? Because we already have 3 bispecific antibodies targeting BCMA. Do you believe that we need to have 4 or 5 or 6 bispecific antibodies? Well, maybe to reduce the cost, but not sure that the cost will be dramatically reduced with more bispecific antibodies targeting BCMA. What do you think about schedules, IV, sub-Q? What could be the best option, in fact, for your patients?
No, I think you actually addressed the major point. It's number 4 on the market, which will make it not easy for etentamig to actually find a sufficient number of patients, because I think we all have experience with other BCMA targeting bispecifics, and so it's always difficult to change the strategy. I think we're all conservative, and if we have been happy with one bispecific and know how to handle it, it's always difficult to change. But I think this one, etentamig, it's very effective. It has the 4-week interval. So these are 2, I think, strong points in favor of etentamig. But I guess it will not be easy to find its place in the growing market of BCMA targeting agents for multiple myeloma. But I
Although,
think
if I may
maybe
add, Philippe, a point as well, just to, we have to recognize, though, these are phase one early
yeah.
data, right? So I think with longer and maybe phase two, we'll see a bit more result. I'm still thinking because of his ability to do the dual binding to BCMA, we may see a little bit more response rate and longer PFS once we know the right dose. So I want to be positive because in that case, to your point, Philippe, we may have a better choice based also on efficacy. But right now, I will agree, not knowing what is happening after these 13 months of follow-up, I think is still make me think like Hermann is still another option, but what is different is not clear yet.
So,
okay.
Paolo, do you have data that etentamig is actually working in certain patients that have BCMA mutations that mediate resistance to teclistamab and elranatamab? That would be very important.
Yeah, unfortunately, we don't have access even
Okay,
preclinical to
okay,
the molecule,
okay.
but there's
Yeah,
definitely a good point that
yeah,
can help us to differentiate it
yeah.
based on overcoming mutation.
Thank you. And the last question for both of you. You heard about the tri-specific antibody story, and we are here discussing about the phase one, with the etentamig, a short follow-up still. But tri-specific antibodies will come maybe on the market before. So do you think this is a revolution for patients based on the early data that we have? In fact, short follow-up, small numbers, but very interesting indeed. So Paola.
I will start by saying, yeah, I will agree the 100% response rate is fantastic. We are going after to target and we're seeing much more response. My concern, again, I'm wearing more my preclinical hat in the lab. Are we going to select patients when they progress with a dual escape, like dual loss of dual target, and then will be an issue. But to your point, right now, they seems to be, number one, more efficacious. Number two, also from the safety point of view, you highlighted the fact that even if we combine two, we go after two targets, the safety, like we see less side effect related to targeted BCMA, GPRC5D. So the fact that they have a low affinity for CD3, for example, make me think that will probably is the key to prevent infection because we don't have these T cells engaged all the time to go after the tumor because CD3 binding for the trispecific is a low affinity. But I think, moving to thinking about the future, if this therapy show efficacy, but of course durability of the response, that I think will be, we definitely is a great option that for sure will make a difference for our patient.
Hermann.
Yeah, I was also very impressed about the tri-specifics, and there was another tri-specific also presented targeting BCMA CD38, also still in the escalation step, but also interesting from the concept. And I think also the every 4 weeks application, the one step up dose, the rather low GPRC5D related toxicity, and I must say the 1 year progression-free survival of 95%, that was really convincing. But I'm with Paolo. I think Paola, I think we have to wait a longer follow-up, but at least the first data that we've seen, and this is quite a large number of patients, is really, really promising. I think on the longer run, we have to see whether we are going to induce GPRC5D and BCMA mutations, losses. And then the question is, what can we do in a patient who is failing this kind of treatment? Then we probably need new targets. But we have some time to search for new targets.
Maybe we have the cure, Hermann, and so
yeah,
then we
that's
we don't have to worry about
you
this.
are optimistic. Yeah, yeah.
Yeah.
Thank you so much, Paola. Thank you, Hermann, and thank you for this very optimistic conclusion.
Thank you, Philippe.
Thank you. Yeah.